Hello, and welcome to the Empowered by Victorious podcast. This is Stacy Orsborn coming at you today. I have with me you are a doctor, Mary Jane Glade, nurse practitioner and owner and founder of Wellity here in Lincoln, Nebraska. She was on our previous episode just talking about who she is and how she's serving the community of Lincoln, but also our hot topics. So, hot topic last time we've talked about GLP-1s, maybe taking a little bit different stance than the traditional public right now, just, serving women in front of us. And that's what we're all about here, and as well as Mary Jane. So today I had her back on and we were talking, and I think hormone replacement therapy is kind of where we're falling today in regards to education and awareness and empowerment for women. Mary Jane, I would say, let's just jump into this here. Historically speaking, in the past, hormone replacement therapy has had a pretty bad rep. What was it, 2005 when that study came out back then? Maybe speak to that a little bit and, what that, without debunking it, let's go into why that study is no longer like a quality study later, but at the time, the recommendations and kind of how the medical world responded.
Yeah, so I graduated with my master's in 2007. That's when I started practicing as an NP. And it was very much taboo. With the Women's Health Initiative study, it came out, questioning whether or not there was a higher risk of breast cancer, higher risk of stroke, higher risk of heart attacks in women who were on hormone therapy. And really, we've debunked that now. Again, like you said, it's very much not the truth and not the fact of what happens with hormone therapy when you utilize it safely. But yeah, when I got out, it was like, don't even talk about it, get everybody off of it. They should not be on any replacement therapy. Let's find other ways to kind of manage things. And then I actually got in to work with an obstetrician gynecologist who is very much hormone positive, regardless of the study, and taught me a lot about, the flaws of that study and what it really should have been, how it should have been studied, who the population should have been in that. And really got me on a better path in regards to hormone therapy. So I have been prescribing hormone therapy for a long time, even in the midst of that study. But that's a rarity. There were so many providers, and they rightfully so, it came out and was presented in a false way. The data was not strong in regards to, or it wasn't presented strongly on who was on the hormones and what their age was and what that population base was.
Because a lot of it was after the age of 65, right?
Yes.
From my understanding.
The average age in that study was 61. That started on HRT. Yep.
And starting on a hormone replacement therapy, just to educate people a little bit, when you've been off hormones and, hormones have not been present, estrogen and progesterone, obviously, is kind of what we're talking about in regards to female specific hormones. Whether that was through menopause or whether that was through, a hysterectomy. Back then, I still feel like taking the ovaries during a hysterectomy was fairly common practice, versus trying to leave those, so women had been without estrogen and progesterone up to this point for 30 to probably 10 years, 20 years, and the risks of breast cancer, all heart disease, all of these different things that come with losing those hormones naturally or unnaturally. So that risk was already elevated because the hormones had been gone. And then when you're putting in a hormone replacement therapy, in a study like this, it almost implies that that's what caused it. But really, you have to look back. You have to look back as to why, they very well could have been already on that journey and probably were already on that journey.
Yeah. Some of them had events already. Some of the women were smokers, 10, like you're talking about, it's not ideal to start hormone therapy 10 years after menopause. I mean, we know what estrogen does in our vascular space and how putting people on estrogen after such a long period of time can really be more harmful than beneficial at that age, So obviously in smoking increases your risk of these things. And some of the women had known cardiovascular disease before they started HT.
You're right. Right. And so, I mean, I remember just like the fear mongering around it. And, these women, I remember, I believe my mom had a hysterectomy right about that time.
Mm-hmm.
It would have been a few years before that, and she had been on hormones. Her hysterectomy would have been in 2001. And so she had been on hormones, and then the 2005 study came out, and she came off of them. And that extreme shift, I remember, like, that,
Yeah.
the extreme symptoms of the
Mm-hmm.
hot flashes and the roller coaster,
Mm-hmm.
the weight gain, like
Mm-hmm.
all of those things, like it was so extreme to come off of it, so quickly, which we see in, you know, hysterectomies in general when hormones are like no longer present, or after breast cancer treatment when it's a very extreme shift like that. But luckily with perimenopause, menopause transition, you kind of see a minimization of that extreme fluctuation. But it starts to, obviously the symptoms start to increase.
Mm-hmm.
So when it comes to hormone replacement therapy, or HRT is what we'll call it for the sake of this episode, but HRT standing for hormone replacement therapy, what is obviously the primary purpose here, you know, in regards to when you're prescribing this method of treatment?
Well, for me, it's number one, quality of life. I mean,
Mm-hmm.
it's indicated for, hormone therapy, and I call it hormone therapy because not everybody's necessarily in a replacement sense, but
Sure.
so I always call it hormone therapy. If you hear me say that, just know we're talking about the same things. Um, Quality of life is number one. I mean, we get a lot of benefits in the right population for hormone therapy, but we want people to feel good, like, and you and I talk, like, sleep is a pillar of health. Like, you have to sleep to feel good, to have your metabolic health good. And that is one of the biggest things that happens to women in this transitional period, whether it's perimenopause or menopause. They can't sleep. They can't sleep.
Yeah.
They're hot flashing, they're night sweats. So many things transition from that. So my number one reason to prescribe or to recommend or have the discussion is quality of life. We know that the
Right.
benefits kind of trickle down from that, but
Right.
number one, first and foremost, like, you have to feel good. Like, you're not gonna lift weights. You're not gonna sleep. You're not gonna want to be in relationships. You're not gonna want to do things with your family if you don't feel good.
Absolutely.
Mm-hmm.
Absolutely. Like quality of life, sustainability. Like, I think what's interesting here is I think that estrogen specifically I don't think people are as educated in regards to what estrogen actually does for a woman,
Mm-hmm.
beyond just like being a female reproductive hormone. It gets a lot of that attention, but what it doesn't get attention on is everything else that it does. Like, you know, testosterone, I think people can associate what the benefits of testosterone does for a man. It's
Mm-hmm.
essentially the same thing for a woman.
Absolutely.
Estrogen being so vital
Mm-hmm.
to all major systems,
Mm-hmm.
literally all major systems.
Mm-hmm.
So when you see women starting to, enter perimenopause, a lot of times, like you said, it's not necessarily a replacement situation, but are you, you know, because a lot of times, from my understanding, within perimenopause, we're seeing fluctuations where sometimes estrogen is in excess,
Yeah.
or progesterone isn't as high as it should be, essentially, is probably more so the case.
Right.
Like that balancing act, how are you, because really in the end game, estrogen's going to go away,
Yeah.
right? Like the natural estrogen's going away, but in that fluctuating state,
Mm-hmm.
sometimes they can be too high.
Mm-hmm.
So how are you navigating those stages with the hormone therapy?
So we always start with, conversations about, like, what their wellness and health goals are, like what they want to see. So that kind of guides, like, what we initially talk about. But you're very right. Like, which we'll talk about in our workshop coming up, is hormone fluctuations. People think perimenopause is really a low estrogen state, and it's an erratic state, right? You have like major high estrogen, which causes symptoms, and you have major low estrogen, which causes different symptoms. And then you don't have progesterone to balance it. And then we get into the whole, like, how good is your liver? How good is your gut? Like, all those things that play a vital role in estrogen metabolism. And so it's kind of an all-encompassing picture. Perimenopause is a difficult time in a woman's life. without good guidance, right? And I say, like, what I do for one will never be the same for everybody because it's so different depending on their body mass, you know, what type of fat they have on their body, how they're moving their body, like what they're doing. For all of these things makes a huge impact, because obesity, we know you have all this exogenous estrogen that isn't good estrogen. And so, you know, people are like, well, I'm thin and I have these symptoms, or I'm overweight and I have these symptoms. And it's very different to see, but you can tell like what type of estrogen is going on in their system and what they need. So a lot of times it's a balance with, like, maybe we start some progesterone, because if we balance your progesterone a little bit better, then you're going to have better balance in your estrogen, you know? So it's very different person to person. Take into account how they're cycling, if they're having irregular menstrual cycles or regular, that you have to take all that into account, because if you have a uterus, you cannot be on estrogen therapy without some sort of progesterone balance. You put yourself at risk for buildup of the lining of the uterus and then potentially uterine cancer. So it's a very, very different balance for every female. But again, it goes back to like what they want to see, what they want to feel, you know. If they're having, you know, midsection weight gain, fatigue, puffiness, varicosities of their veins, migraines, headaches, that's very much an estrogen high situation. If they're hot flashing, night sweats, you know, sometimes low BMD, so their bone density is lower. Obviously, we know that's more of an estrogen state that we have to talk about and kind of address. So it's the conversation, and then we figure out kind of what that balance needs to be. I'm not one that...
The second one was progesterone, right?
Yes.
Progesterone situation.
Mm-hmm. Yeah. So
okay.
A lot of perimenopause, it's balancing out that estrogen, making sure you're detoxing well, keeping your liver, gut healthy, and then adding, you know, that progesterone, maybe cyclically, and then maybe we add a little bit of estrogen on the front end when you're low in that menstrual pre-follicular phase. And so it might be like we do cyclic hormones to kind of mimic what we want to see and what their body feels good at. So it's just finding that healthy balance. And I know there are places and people who be like, okay, we're going to give you 5 things, 5 prescriptions. You're going to start them all. And then they're like so confused because they don't know what's helping, what's hurting, the side effects or whatever's happening. You don't know which one it is. So I'm kind of a start low and slow, and then obviously bring people back frequently to talk about like, how can we optimize? Where do we need to add? Where do we need to change? And make sure they're starting to feel better.
Yeah. I love that because I mean, and you know, we're speaking specifically to like perimenopause, obviously kind of more specific right now, but like, let's use an example, like somebody like myself, like I am not necessarily in perimenopause. I'm 37 years old. I think what people don't necessarily understand about perimenopause is it can start really at any stage and it can last a long time. So I know from like I'm assuming, I guess I don't know for a fact, but you know, I have a feeling I will probably enter perimenopause a little bit sooner than, you know, the traditional 45, like right around that age group. I can already kind of see signs and symptoms of it starting. You know, I'm very regular with my periods still, very consistently, but my periods are like changing a little bit, like they're a little bit lighter or they're a little bit heavier, depending on the month and that type of stuff. But the other thing is like, I started my period when I was 12. I'm pretty sure. Like I was pretty young when I started. I also had babies very young. Like I was 21 when I had my first child. And I actually was pregnant before that as well. So, you know, I think that there's a lot to be, you know, just knowing what I know of my medical history in that way. I know I could potentially I'm a candidate for probably reaching perimenopause a little bit sooner than maybe 45.
Right.
And, you know, we've done a little bit of hormone therapy with me in my treatment plan with you. So it's not that I'm in perimenopause necessarily. It's just like quality of life and like balancing things out. I live a very stressful lifestyle.
Your cortisol?
Between my cortisol is a little high. And it does affect things. I think that people think that like, you know, it's just this like woo-woo stuff of like adrenals and like all that stuff. Like it's real. Like the lifestyle component, your medical history, like it's all encompassing, right? So let's maybe just use my case for an example here. Like with that blood work where we decided to use testosterone
Mhm.
replacement, what did you see in the labs, and like how did you come to those
Mhm.
conclusions within that treatment?
Well, adrenals play a big part of it, and I don't think we don't have the perfect, calculations for everything in that. But when you have more adrenal stuff going on, so your higher cortisol, your adrenal glands are stealing some of your hormones, right? So they're kind of stealing that testosterone and that progesterone to keep functioning. And so that's where you can kind of see some irregular menstrual cycles, heavier cycles, low libido, low muscle mass, depression, anxiety. I mean,
Mm-hmm.
we see all the commercials for men, right? It's like la 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 la
Mm-hmm.
la, everything, low testosterone, low T. That happens in women just the same,
Mm-hmm.
And
Mm-hmm.
so, like, looking at the whole picture, we know how those hormones play into like neurochemical development in our brain and help balance that. So that was one of the keys for you that I knew we needed to support that because of everything else that was going on. There was no way for your body to naturally be able to be like, hey, I'm in a good state right now. I'm just going to make what I need and keep going because we need to support kind of the other processes that are happening. And so all the symptoms we talked about, I was like, this is going to be key in you can have low testosterone and not be menopausal. Like it is a
Right.
very common thing for women because of the so many hormone components that we're talking about. Your thyroid, your iron levels, like all that stuff factors into it. But that is one of the supplements or hormones that we can really work on to make women feel better at a young perimenopausal age.
Right.
Yeah.
Right. And then not being afraid of that, right? Like
Mm-hmm.
I think I looked at you like, okay, like am I gonna grow body hair in
Right.
weird places?
Yes.
I will tell you, just public service
Uh-huh.
announcement. I was on a very low dose still, but like, and I really haven't been consistent with it, to be honest with
Yeah.
you recently. But um,
It
I
hangs
went
around for
through
a
laser.
while. It hangs
Right,
around. Yeah.
right. I went through laser hair removal before
Mm-hmm.
starting it. I did see an increase in what was there, like not in a bad way or like overwhelming way. I just had to go back in for another treatment
Yeah.
because I was like, oh.
It's working.
And she was like, has anything changed? And I was like, well, I've been doing some hormone stuff. And she's like, oh,
Yeah.
that'll do it. And
That
I was
makes
like,
sense. Yeah.
okay, well, yeah,
Yeah.
that makes sense.
Yeah.
So just public service
Yeah.
announcement. If you've had laser hair removal,
Yeah.
like that could be something to just
Oh,
be aware of.
there are risks and benefits, and we talk, but we're not like maxed, like high dosing women. And that's the
No.
key. It's like when and we're not doing pellets. Like I do not do pellets. I think
Mm-hmm.
you put in something that is there and you can't adjust it for a period of time. That doesn't excite me. So I choose not to, but some women do great on them and it's just your choice of whatever method you want to do. But it's also just you just giving your body what it needs and not in excess so we don't
Right.
experience the bad things that could happen and we manage anything like acne is a really common problem when you're doing
Yeah.
testosterone therapy. So a good skincare line that works really good to help with that, or so we have different ways to help, like antibiotics, gut health, various different things. You're not out there like, oh, I'm gonna live like I'm a puberty for years to
Mm-hmm.
feel good.
Mm-hmm.
Yeah.
I feel like I saw an increase, but I feel like it was actually worse before we started
Okay.
because I think my estrogen was so high that
Mm-hmm.
like I was having really extreme like hormone
Mm-hmm.
fluctuation acne like right before I started my period.
Mm-hmm.
And then once I started I obviously the testosterone, but the other supplements that you have utilized. I think, getting those just the levels,
Right.
like it's never going to be perfect. Like I
Mm-hmm.
think that's the other thing that people think, like, that your hormones are like this, you need to keep them in this perfect
Yeah.
homeostasis state where it's like this perfect fluctuation. And it's almost impossible
Oh,
to like
yeah.
maintain that.
Mm-hmm.
And so, finding the balance of like, okay, this is just like part of life,
Right.
but also like, how do I live my best life,
Mm-hmm.
and what can I do to help support live my life,
Mm-hmm.
me, and on the journey of my best life. When you were talking about estrogen more in depth there, I mean, I think that it's important to point out like the correlation of estrogen and women's ability to put on muscle. I think that that side of it is very
Mm-hmm.
understood, or like not
Mm-hmm.
understood, especially for women as we approach perimenopause and then, postmenopause.
Mm-hmm.
Um, we're losing muscle mass over after the age of 30 if we're sedentary very quickly,
Mm-hmm.
anywhere between 5 to 10% a year, or, every 5 years or something like that. So like it doesn't sound very quick, but it happens fairly quickly. And so just maybe speaking a little bit to that side
Mm-hmm.
of the benefits of estrogen, and having estrogen present in
Mm-hmm.
your body in a healthy way.
Mm-hmm. Yeah, I mean, we have estrogen receptors everywhere, I mean, all over our body, brain, vascular, pelvic, tissue everywhere. So it affects almost every body function, everything in our system, our skeletal system, our our muscular system, all the things. And to keep those things harmonized and healthy to be able to build and maintain that mass, we have to have it. I mean, like, it is vital. That's why osteoporosis is so common, because of after menopause, especially thin women who don't have a lot of muscle mass to start,
Mm-hmm.
or have a lot of body fat. Decreases in estrogen can make that significantly worse, but,
Right.
yeah, bone mineral density or muscle mass in general. I see it all the time. It's like we start losing so much mass in our, our large muscle groups, but then we're starting to get midsection fat, because
Mm-hmm.
that's estrogen changes, right? So where
Mm-hmm.
does it come from? Where's it going? Like, how can we build? And we know protein. I mean, protein is huge
Right.
for all ages, but menopause for sure, for so many different
Right.
aspects. But to help with that metabolism, muscle mass build, and then we combine that with estrogen, it's great. Goodness.
Well, and people, there's different types of estrogen, right?
Yeah.
There's like 3 different types of estrogen that your
Mm-hmm.
body is naturally
Mm-hmm.
making. And I don't remember which one goes where, and when
Uh-huh.
which one
Yeah.
stays
Yeah.
or how. And
Mm-hmm.
I know one of them is more related to pregnancy.
Yep. Mm-hmm.
And then there's two other ones,
Uh-huh.
and one of them changes and one of them
Yeah.
shifts and kind of takes over. Um, I'd be curious your thoughts. I believe that the body is so innate, and it is so smart, and it is so um, divinely designed, in so many ways. Why do you think the body is designed to slowly deplete such an incredibly important hormone, and hormones,
Mm-hmm.
in a woman as she ages? Because I think there's, like the stigma of menopause and the stigma of perimenopause and the stigma of all of those things, like our value starting to
Mm-hmm.
decrease as we can no longer procreate. Why do you think something like this I mean, obviously we're living longer, so
Right.
I think that there's a little bit of that, but I'm just curious with that. Like, it's an interesting, like, process.
Yes. Yeah. So do you think that perimenopause is happening sooner? Is that what we're kind of like going towards? You think?
It kind of feels that
Yeah.
way.
And I don't know. There's probably the potential. I think a lot of things in our nutrition, our lifestyle, like, we talk about this all the time, like being the women that we are and the demands that we put on ourselves. I mean, all that kind of rolls
Mm-hmm.
into our whole harmonized hormone endocrine system, right? And they're
Right.
things we cannot get rid of. We're not going to stop being a mom. We're not going to stop being our career person or whatever that is. But we have to find that balance to keep our harmonization in our system as good as it can be. Um, but I'm sure there's other, I mean, we're living longer, but it seems like we're aging faster. And it's like
Sure.
we have all these measures to keep us alive, but yet is that the best alive we can be? And so I talk about longevity. I do think there's a big like gut component, and nutrition, all those things. And then hopefully our young kiddos aren't getting too much processed stuff to change their hormones early on to make it not as effective or efficient in our system, all those things we could get into like hours on end. But the good thing is we have tools, right? Like, we have the ability to help women to
Right.
acknowledge and to treat. And so I think that's one of the key things that, okay, we might be seeing these changes earlier, yes, but we have the knowledge and the tools now to be aware. And that's the other thing. I think there's more awareness about it, because back when, I ask women, I'm like, when did your mom go through menopause? And a lot of times they don't know, or they know exactly because of how they
Mm-hmm.
saw her start to change. with no help,
Mhm.
and they just functioned. They just didn't know that that was to be expected, or that there was ways to help. And so that awareness, I think, where we're like, yes, this doesn't have to be the way it is that happened to your mom or another female that you knew at that age. And same for like people who get hysterectomies, you don't have to suffer, without
Right.
treatment. So
Right.
yeah.
I know it's an interesting, like, we have tools for a reason.
Mm-hmm.
We live in a completely different world than we did back in the day.
Right.
Our stressors are completely different. It's consistent, like the amount of information we're processing, like all of those things, like
Mm-hmm.
for people that want to live a more natural lifestyle or like,
Mm-hmm.
lean on those, like, I don't want to take, you and I've had this conversation, like, I don't want to take a sleep aid if I don't have to,
Mm-hmm.
or I don't want to, I don't want to take hormones if I don't have to. Like,
Mm-hmm.
it's not as simple as just living this like perfect
Right.
homeostasis
Mm-hmm.
situation
Mm-hmm.
where you don't need that for the
Mm-hmm.
quality of life to be maintained.
Right.
And there's no shame in that.
Yeah.
There's no shame in getting getting your hands on these resources and talking with your provider about, you know, hormone fluctuations,
Yep.
or,
Yep.
or feeling when you feel off. Bethany and I had this conversation in the gaslighting episode of just like, women are speaking up more and more and more. We're asking questions. I have a theory that millennials are just like demanding information. Like the millennials are like,
Yeah.
hello, like
Hello.
this is
Right.
not okay.
Mm-hmm. 100.
Um,
Yeah.
and it's changing, and it's
Mm-hmm.
changing very quickly. Like I think of my mom. I'm pretty sure she was 37 when she had her hysterectomy, and it was a total hysterectomy. Ovaries, everything, and I can't imagine. Like I'm 37. Like I cannot imagine, and the implications of what that has like mentally, physically, emotionally, like put on her as she's aged. Like it's a real thing. Like, and people need to be able to like speak with their providers in a way that they can ask questions and educate themselves and come up with a treatment plan that works for them.
Yeah. Totally.
Yeah.
Yeah.
Um, what do you, as far as different types of hormone therapy,
Mm-hmm.
what does that look like
Mm-hmm.
for, like, if it's creams or oral, or
Yeah.
like you mentioned pellets?
There's so many different forms. There's pellets, there's creams, there's bioidentical, there's compounded, there's FDA approved, through your retail pharmacy, which a lot of those are even bioidentical, which people don't know. Like a patch, is great to use, and it's twice a week.
Mhm.
It's transdermal, which is a safer route than an oral route, especially for looking at cardiovascular risk factors and various things, which you have to take into account. Um, there's so many options, for women. And if you have a uterus, if you're postmenopausal, progesterone cream is not going to protect the lining. So if you're postmenopausal, you need to be on a usually oral type of progesterone to balance out estrogen in the lining of the uterus, or a stronger patch or something like that that has some progesterone in it. But you need to be on something that's going to really support that lining more so than just like a transdermal, bioidentical compounded progesterone cream. Premenopausal, that's fine to use if you're depending on what your needs are and things like that. I prefer and use primarily patches, so estradiol patches. They work well. Very low dose can be effective. Balance it out with some, progesterone orally that's safe, plant based. Those are kind of my go tos. I have women who are uncompounded and they feel great and they do well too. Nice thing about compounded is you can use different types of estrogen and still a transdermal route, and you can adjust the dosing a little bit better. You can still do that with some of the other, formulations and methods too, but that's one of the benefits of that.
So you're kind of obviously trying to balance out estrogen levels during
Mm-hmm.
perimenopause, and even probably before women are getting into perimenopause.
Yes, yes.
Trying to like balance all of that out, just because
Mm-hmm.
we know estrogen has a tendency to try to roar its head a little bit more than it needs
Yep.
to, and increase progesterone levels, which is due to stress and everything
Mm-hmm.
else. When it comes to staying on that treatment type of treatment plan, so you know does it delay the onset of true menopause when we're doing hormone therapy in the perimenopause stage? And then, post menopause, which we consider someone menopause after they haven't had their menstrual cycle for 1 year.
Correct.
Do you keep them on that then the rest of their lives for quality of life? Like, what does that look like in regards to like transitioning? Or is this just a continued state of treatment and, balancing and blood work and that type of stuff?
So again, it's going to be individual for everybody. There's people who you start on therapy in perimenopause, and then once they stop cycling, you might not cycle their progesterone. You might do something different with that. Be like, okay, now you're not having menstrual cycles anymore. Let's change your therapy depending on how they feel. Sometimes the blood work helps. You could diagnose, perimenopause without blood work, and it's just another little clue or key, and same for menopause. And so somebody, like, if they come to me and they're on an oral contraceptive pill and they're 51, you don't know. You're like, okay,
Right.
are you menopausal or are you not? Like, if I take you off this pill, what are your ovaries going to do? What is your body going to do? So in that situation, I have them stop the pill, and then usually we do blood work, like, depending on how long they've been on it, what they're doing, a period of time after being off the pill, so I can see what their hormone levels are, if they're starting to do anything cyclically. The other thing is we have to take into account risk of pregnancy, for these women. So depending
Right.
on what they're using for therapy, if there's any risk of getting pregnant, obviously we're not going to talk about doing testosterone therapy. We have to be on something that's very protective for that. And then, we don't want them to get pregnant if they don't want to get pregnant, and hormone therapy in the sense that we're talking is not contraception.
Right. Right. And it does not delay menopause necessarily, right?
No,
Or does it?
no. I think, we know your ovaries are going to kind of do what they're going to do. Same for your adrenal glands, same for your brain, the hormones that are produced by your brain to get your ovaries to do something. They're going to do what they're going to do because of your own system. So it's just
Mm-hmm.
supporting that process. And then
Mm-hmm.
if we're getting their other things in check, lifestyle wise, then we could potentially just continue really low dose, right? Like if they're,
Okay.
maintaining, less abdominal visceral fat, their inflammation markers are good. They're doing lifting, they're exercising, those types of things. Low dose can just support what they need for what they used to have, if that makes sense.
Yeah. Yeah. And not only from like we're talking quality of life, but also like from disease prevention,
Yes,
right?
100%.
Like that's
Oh,
a huge factor, especially after, you actually reach menopause, reducing your risk of all sorts of things, correct?
correct. Yeah. Osteoporosis, loss of bone mineral density, fractures, reduced risk of colon cancer. We think potentially some dementia prevention, protection
Mm-hmm.
there. Obvious, so many different. I mean, everywhere you think the estrogens in your body, if we're supporting it in a healthy way, we're going to reduce a lot of other risks. I mean,
Breast cancer.
breast cancer, skin health, pelvic health,
Mm-hmm.
intimacy
Mm-hmm.
issues, bladder urgency, leakage. All the things, muscle mass.
Yeah, that's a good point too, because I mean muscle mass and all of those things going down with estrogen, but like also like pelvic floor, like
Mm-hmm.
prolapse, like all of those things, like as estrogen starts to go away, like those things start to get worse,
Yeah, and then you stop
just
exercising,
naturally.
and then you stop
Right,
exercising because you don't want to wear a pad all the time, or you
right.
feel discomfort there, or you don't want to be intimate because you have pain, or you have, I mean, so many
Dryness.
dryness. Yep. Yes. Yeah.
Yeah,
Recurrent
yeah.
infections, recurrent UTIs. Urinary tract.
So does it make sense for somebody in their 70s that let's say somebody has
Mm-hmm.
been on hormone replacement therapy since um, you know, transitioning into menopause
Mm-hmm.
at the age of, let's say, 55 or whatever, would it make sense for somebody in their 70s, 80s to like continue on with some kind of treatment? Or is there a certain point where it's like, okay, like, we're not gonna do this anymore?
I usually start having the conversation 60 to 65. Obviously, it's very individualized how active they are, what their family history is, how their other cancer screenings are. But, genital urinary treatment, like pelvic treatment, can go on forever. I mean, there's very low risk.
Right.
So, localized estrogen, testosterone, DHEA, various other different formulations we have, you can use that, for forever. I mean, I have some, very mature women who are on because they don't want to get UTIs. and they want
Right.
to be intimate, or they don't want to have itchy, discomfort, dryness, I'm like, it's totally safe.
Right. Right. And that's okay. Like
Yes.
quality of life.
Yes.
Absolutely.
Yes.
Like I would prefer to like be as
Right.
comfortable in my own skin
Right.
for as
Yes.
long as I can. Like, I mean,
Yeah.
there's no reason that I shouldn't be able to reach my dying bed and not like feel like, okay, like
Yeah.
I feel pretty good.
Right. Exactly.
Like I've lived my best life.
Yeah. Stop all beds.
Right, right. With the one of the things, anyway, I mean, and we'll talk more. So for those of you that are in the Lincoln area, Mary Jane and I are going to be hosting a ladies' night workshop conversation on perimenopause specifically on August 22nd from 6 to 8 p.m. We're going to kind of make this like a ladies' night, fun night. But I think that this is going to be directed for women of all ages. I think people in postmenopause can get a lot of information from this, but people like myself and younger than me, like there is so much information, and knowledge is power. And if you know what's coming and know the ways that you can navigate this best, and the quality of life that you could maintain by educating yourself is so important. So if you are interested, we will put a link in the show notes here for a link to sign up for that event. But our goal on that is to really, I think that menopause and perimenopause is finally getting its attention within the public realm. Like I said, like I think Huberman had, Stacy Sims and Marie Claire and like all of these people on his podcast just recently. Jay Shetty had him on. Mel Robbins is having these experts on. Like everybody's starting to menopause and perimenopause has a buzz around it, and I swear it's because millennials are hitting it, right?
Probably.
Like
And Oprah.
like the
I
millennials,
mean, like,
right? And
big
Oprah.
people are
Yep.
Oprah, and then who's the other? Oh my gosh, I'm totally like, she has her own like line of supplements now that is supposed to be driven towards, I can't remember who it is, but yeah, she has her own stuff now that she's selling or marketing, that supplements to help build
Yep.
estrogen and all the things. Yeah. I think yeah, there's been lots of talk shows, lots of celebrities starting to talk about it, Yeah.
Yeah. And I think that women are just functioning from a completely like unawareness when it comes to exercise, like what you should be doing. We know strength training is important. We're aware of that. I think everybody kind of gets that now. But the type of strength training you're doing in the perimenopause stage and in postmenopause is different, and it should be different. The high intensity intervals are still important, but they're supposed to be at a certain level. They're like, it's not just the steady state cardio is good for your heart, maybe once a week, maybe twice a week. Like that stuff is good, but too much of a good thing is actually like the opposite here. And so women like that are putting on midsection, body fat out of nowhere, like a lot of times, and I'm sure you hear this in your clinic, like, hey, Mary Jane, like, I don't know what's wrong with me. Like nothing's changed. Like I'm not doing anything that I wasn't doing before. I'm eating the same way I was eating. I'm exercising the same way I was exercising, and I'm gaining weight, and I don't understand why. And it's specifically in my midsection. Like I don't know what's happening. Yes, like the hormone replacement therapy or, hormone therapy can help with that. But there's also the exercise component that has to change. And it's I'm just really excited about it because I think that you're going to speak to, the clinical side of how you can support, and how a practitioner that they can reach out to should be able to support them, or what questions to ask. But then from our side, like the fitness aspect of like, okay, this is how you should be training. This is how your exercise should shift, because the hormone fluctuations create increased cortisol and stress, and you decrease your ability to recover. Like you said, what else is it getting affected? Sleep.
Insulin resistance. I mean, that's huge.
Right.
Perimenopause. Yeah, so many things. Yes. And I'm going to shout out to Victress, because you guys have actually made changes and advanced education and knowledge and developed programs that are specific to these transitional periods for women. It is not just a one size fits all, just like how I practice. You go to Victress, it is not one size fits all. You're going to do the same workouts, same things that this 25-year-old who has awesome hormones supporting her than you at 45, 47, 48, 50, even sometimes in our early 40s, which shout out
Right.
to you guys for actually putting in the time, energy, efforts to learn that. And we've had conversations about this for my cancer patients, that are now void of all their hormones, but they have different restrictions or different needs based on what they had for their treatment, but they still want to be strong and they still want to do what's appropriate for their body. We have to be with individuals who are trained and understand what the needs are at those various stages, because that's how you're going to be successful and that's how you're going to start feeling better and help your body to support it as much as it can.
Yeah, absolutely. And I think the other thing is, like, when it comes to muscle building, like, your 30s are prime for that. Like, your 20s, yes, but like your 30s really is, as a woman, is like when you're at an optimal level of,
Yep.
putting on muscle mass, not bulking, like that's not what I'm saying, but just like putting on muscle mass in a way that you can sustain it leading into perimenopause and, postmenopause. Like, I love seeing these photos. It's very few and far between right now, but I feel like it's going to start to become more popular. It's like seeing these women that are 55, 60, 65, and they have like delts and they've got biceps and they like have, like, you just don't see that a lot.
No.
And I like, it's possible. Like, it is 100% possible. It's not like you're just going to deflate away. Like, there are things that we can do to help you, from your side with hormone therapy, and then from our side with the intentional exercise programming in a way that you can be that grandma.
Oh, for
Like,
sure.
I want to be that grandma.
Yeah. At 42, I mean, I used to do a lot of cardio. I used to think that was the key. I need to have my heart healthy, my lungs. So intervals, running, miles and miles. And then it wasn't until I started doing high intensity strength, heavy weights, learning my form, that I could see even my body changing. And I'm like, thank goodness, because I have a horrible osteoporosis in my family history. And that's not going to be me. I'm going to do what I can. And, it also feels good to be strong, for women.
Right.
So, running and doing marathons and all that is strong also. But if we can work on also the strength component, I mean, the confidence that gives women, obviously, when we're talking about dopamine, testosterone, all those things that come from weightlifting and helping make those hormones more effective in our system, I mean, that's all key.
Right. Right. Well, and muscle, we're not even going to get into the benefits of having muscle mass on your body.
Right.
Just,
Yeah.
like, that's just like
That's
a whole nother, like, if we're talking about estrogen dominance and like estrogen excess, when you have less body fat, more muscle on your body, like, that is just going to mitigate a lot of those like potential risks and, excess levels. So yeah, I mean, that's a whole nother conversation.
Yep.
But thank you first and foremost for being on here and coming on. Like I said, the workshop is going to be August 22nd here in Lincoln. We haven't decided if we want to do like a recording of it yet. That's probably something we should check about. Like a virtual recording if people want to listen or get access to. But really specifically, I think that, knowledge, like I said, is power. And whether, if you're a Wellity member or a Victor's member, you're going to get a discount on your entry fee. But really, it's just going to be about like empowering women leading into. And so I think everybody gets scared of like, I don't want to gain weight. I don't want to like, struggle with these things. And I know it's coming for me. So
well, and I also think it's very sad, and you and I hear it all the time. And Bethany talked about the gaslighting. It's like, women are asking some of these questions, but they're not getting answers. It's a dismissed situation. Okay, you're depressed, you're anxious. Yeah.
Welcome to menopause.
Yeah, like exercise more, work out more, eat less calories, which is not the key, So I think that this type of workshop, it helps empower. You can advocate for yourself. You know what questions to ask. And I think that should be something that we definitely talk about. Like, these are the things you should ask your providers. And if Bethany talked about this also, if you don't get an answer or something you feel satisfied with, like an explanation for something, then that you feel comfortable with that explanation, then what are the next avenues to help yourself, so that's something we can touch on too, and have like in our general question and answer component too.
Yeah, some tangible things. And come, if you're coming, like, come prepared with your own study, like your own scenarios. Like obviously Mary Jane can't see your blood work. I can't see your exercise history. Like there's a certain limitation to like what we can necessarily troubleshoot, but you know, I would love to have an opportunity where everybody at least gets a question in, or at least allows us to, you know, address a specific current concern that they have or are experiencing. So you can take away some things and, you know, go to your doctor or whatever it may be, or whoever it may be, or to your trainer, and really come up with a plan that makes sense for you. So I'm excited. It'll be a lot of fun.
It will be.
I mean, we think it's fun.
Yeah, it'll be fun. Food, just camaraderie, you know, get out, little social event, be around the ladies that support you, and
yeah, absolutely. All right, girl. Well, thank you very much for being on here. We'll come up with our hot topic number 3 here in the near future.
Is there a way that people can put in requests? Like,
I can do that. Okay. Absolutely. Yeah. I'll put a poll on here for Spotify. I can do a poll, but and then I'll just put one out in the public and see what people are interested in hearing. So
great.
Cool.
Okay.
All right, girl.
Thanks, girl. All right.
Well, have a great trip.
Oh, yeah. It's going to be great. Kids will have a lot of fun. We'll be out there enjoying it too. And then come back and hit school hard and do the workshop. It's going to be great. Excited.
Happy August. Yes, here we go.
Right.
All right, girl. Got it. Have a great day.
All right. You too. We'll talk to you later. Bye, Stacy.
Bye-bye.
What's up? You need to go potty?